Hello, everybody, and welcome to Ask Dr. Bob. This is where you get to ask me, Dr. Bob Gabbay from the Harvard Medical School and the Joslin Diabetes Center, and former Chief Scientific and Medical Officer of the American Diabetes Association, your questions about diabetes and obesity and all of those kinds of things. And for those of you that are regular attenders, you know that we typically pick a different topic and answer your questions. And for those of you that are new, welcome. And for those of you that are returning, hey, great to have you here. And tell your friends and family if this is helpful. So, what we're going to do this month is to continue a conversation around GLP1s, the incretins, the GLPs, and part of that is because we got so many questions before we didn't get into everything. There is a part one, and if you've not seen that, the kinds of things we talk about are what are they? What do they do? What's the difference between, Ozempic and Wegovy, and what's the difference between Mounjaro and Zepbound? Spoiler alert, they're more or less the same. They're essentially the same, but in some cases, different doses. Um, we talked about the side effects and safety and what you need to know, and how to prevent the muscle loss that can occur with these medications. Then finally, questions about why do so many people stop the medicine? About 50% in the first year. So that's all in part one. This is part two. So let's jump into the questions. And first question was really around people with type 1 diabetes. Um, can people with type 1 diabetes use these medications? Well, you know, the way medications are approved by the Food and Drug Administration is uh, they're given an indication. In other words, this medicine is indicated or is advised to be used for this purpose. Um, these medications were not approved for type 1 diabetes officially. That said, um, prescribers can use it for type 1, and I've certainly used it for many of my patients. Uh, um, and it's considered off label, meaning that it's not part of the label. So, just a little background to know. So, the question is, can it be used for people with type 1? Well, yes, I believe so. And part of that is that about a third of people with type 1 diabetes uh, have obesity. We know that these medications are helpful for people with obesity. So why wouldn't they be helpful for people with obesity that happen to have type 1 diabetes? You could think of it that way. So that group, absolutely. There are many patients that describe real improvements in their blood glucose control and some of the food noise and hunger that they may have. One important thing to keep in mind is one needs to make adjustments in insulin dose typically if someone with type 1 diabetes was to start these GLP-1 type medications. Um, and so you should be monitoring your blood glucose carefully and adjusting, typically decreasing the amount of insulin that you take. So that's the story with type 1 diabetes. Um, the next question, and there were a couple of questions around this, is what's the pipeline for new drugs in this same sort of general category? And I can tell you that it's pretty robust in terms of looking to develop new medications. Um, why? One is the cost of the medication is really a challenge for people. And if there were other versions of the uh, drugs, they may be less expensive. That's certainly the hope. Uh, as you probably know, they are also big money makers for the companies that produce them. And so that's an incentive for many other pharmaceutical companies to try to develop other versions. Um, but interestingly, the I think the most exciting part is that they're trying to improve on these drugs, and so um, there are literally 120 different clinical trials under development for new types of GLP-1. So let me tell you briefly what they are. Uh, there are trials looking at an oral version. That could be as effective or slightly less effective than the once a week injection. So that's one area. Uh, the other is there are trials going on for a monthly version of these medications. So instead of having to take it once a week, only once a month. Uh, and then looking to have other benefits by combining with different hormones. So you probably know that semaglutide is GLP-1 only, meaning Ozempic and Wegovy as GLP-1 only, and Mounjaro and Zepbound are tirzepatide, which is two hormones, GLP-1 and GIP. Well, they're looking at combining the original GLP-1 with a variety of different hormones. With if two hormones are good, maybe three hormones are better. And there's a compound being in clinical trials looking at that. Can it be combined with another hormonal intervention, amylin, or with glucagon? And so all of these permutations are being developed and are actually in clinical trials right now. The other category of new medications in this class are ones to have less side effects. And that's an exciting area as well because we know that not everybody tolerates these medicines. Less side effects would be great. And in particular, a lot of work on the fact that there's muscle loss associated with the weight loss with this group of medications. And therefore, could we do something? Could a new version, a new improved version, not have the muscle loss? And we talk about muscle loss and what to do about that in part one of Ask Dr. Bob on this subject. So you can take a look at that. Okay, so other questions that I got were about some of the other potential uses or benefits of this class of drugs, and there are a lot, and that's what's made this so exciting. Is that not only for people with diabetes does it lower blood glucose, and that's really what it was developed for, but it has other benefits, and I'm going to divide those other benefits into two categories. The first is where we have sort of what we call the gold standard of proof, a randomized control trial. So that's one group of drugs, and that's really the kind of evidence that one needs to get FDA approval, for example. So there's the really well proven examples, and then there are the ones that are what are called from observational studies that suggest that they might be beneficial but not proven yet. So what do we know in the randomized control trial? Well proven. Well, we already know that it lowers the risk of cardiovascular disease, that it helps in heart failure, that it helps in kidney disease, that it helps in liver disease, uh, and interestingly, it helps in sleep apnea, uh, which to date, there are no medications for the treatment of sleep apnea. So there are studies showing benefits in sleep apnea. Uh, Also in osteoarthritis, there's benefit there. And again, there's a good randomized controlled trial to show that. And then finally, for diabetes prevention, for those people at high risk for diabetes, it lowers the risk of developing diabetes by 90%. Pretty dramatic. So all of these are proven in a randomized controlled trial, meaning people randomly either get the drug or don't get the drug, and they compare the results and they see the effect. Then there are a whole bunch of promising areas where it's understudied, but we don't know yet. But there's suggestions that it could be helpful for addiction disorders, particularly tobacco and alcohol use. There's some early evidence there. It may be beneficial in treating Alzheimer's or other forms of dementia. Uh, Parkinsonism has also shown some promise, um, and even cancer prevention and psoriasis. Uh, Really, the list of potential benefits are really quite great. So that's what's made these medicines really exciting. So here is the number one question that I get. I've done interviews with the New York Times and all sorts of publications. And this question always comes up. Can you stop the medicine? Well, let me before I answer that, let me just say I think in some ways it's a funny question to ask uh, because when somebody has high blood pressure and they're put on medicine for high blood pressure, we don't usually ask, can I stop the blood pressure medicine? Well, yeah, you can stop it, but it'll stop working and your blood pressure will go up. Same thing, another example is cholesterol medications. Uh, you know, can I stop my cholesterol medication? Well, yeah, you can stop it, but your cholesterol will probably rise as a result. And that's largely what we know about these medicines, that if you stop them, they stop working and people tend to regain weight. Now, could there be ways to prevent that? Maybe. Certainly, the things that help people lose weight in the first place could be helpful in preventing that weight gain. But generally, stop the drug, it stops working, and you go back to baseline. So I think there's going to be an area of more research to try to understand, but it's maybe an unfair question, and it's a question that we're asking because we're not thinking about obesity as a disease that needs chronic treatment. A couple more questions here. One is this idea of microdosing. On TikTok and elsewhere, this has been a thing. Could you take really tiny doses, microdosing, GLP-1? Could that be beneficial? I think largely I would say the answer is no. Some people, everybody's different, and some people might not need the full dose of medication to get benefit. Sure, that's possible. But for most people, the effective dose is going to be the dose in the range that was studied and the range that's FDA approved. Um, Here's a question I get from my patients a lot. So they notice that they lose weight and they go, I like don't need to worry really about eating right. I can sort of eat whatever I want and I'll still lose weight. Yeah, that's true for many people, but it's not healthy. So just eating junk food is not going to be a good thing to do, even if you're losing weight, because we know that that's not healthy for you. So it is important to think about what you eat, particularly protein, which we talk about in the part one of Ask Dr. Bob on this subject. Um, but to be mindful of what you eat and also to exercise because exercise has a lot of benefits beyond just its effect on weight. So, with that, I'll just tell you that I'll give you a little teaser. If you find this kind of area interesting, which I find fascinating, I post about this a lot on LinkedIn. So feel free to follow me there. And a particular post I'll refer you to is this incredible story of how this class of medicines was looked at for weight loss 30 years ago and um, was turned down by a pharmaceutical company because they thought nobody would ever want to inject a medicine like this. Uh, it's an interesting story, so check it out. Anyhow, we covered a lot of ground today. Hopefully, this was helpful. Please tell your friends and family if they're interested. Uh, Go to check out the part one version of this. And thank you so much for joining me. And I do this because I want to help and I love doing it. So take care and be well.